name is Fred Osher. I'm the Director of Health Services and Systems Policy. We're here to share findings from our early analyses about the behavioral health contributions to some of the issues that were presented this morning. It's obvious, and the two speakers before me have framed the issue why behavioral health is front and center in this dialogue at this point in time, in that there is such an overrepresentation of people with mental illness, substance use disorders, and co-occurring disorders in our criminal justice populations. And what I hope to do in the short time I have with you is present some of the national picture and national data, in part because, as Director Stevenson highlighted, the data to inform Ohio-specific activity is not as robust as we would like, but hence the call to action to generate data that will allow informed decisions going forward. I also want to talk a bit about principles of treatment associated with good outcomes for individuals from criminal justice settings, talk about tailoring some of the evidence-based practices that we know work, that we see so many bright lights and evidence of here within the state of Ohio, talk about what we've learned in our discussions, and I was amiss in not thanking all of you who've given us so much of your time and thoughts over this last year, and we continue to hope and tap into your ideas moving forward, and hopefully have represented them fairly in this presentation. And then end with some key findings that's going to tie into the morning's presentation and suggest directions in developing our framework. As we think about the overrepresentation of behavioral health disorders, starting with alcohol use disorders and drug use disorders in our household surveys, 8% and 2% respectively. In our jails and prisons, 8 to 10 times as much of these disorders are found. As we then move into thinking about serious mental illness, data from a survey of 2 jails in Maryland and 3 in New York, where the national average on serious mental illness is around 5% in our populations, but within jail settings for men around 14.5%, and a take-home finding for all of us to consider moving forward, women 31% meet criteria for serious mental illness when booked into our jails. That overrepresentation continues within our prison population and is fairly consistent upon all correction populations. We can expect similar rates as we move into jail, prison, and community corrections. This is a summary slide amplifying some of the data Director Dawson presented earlier. We've got a corrections population, 70% meet some criteria for a substance use disorder, 50% for dependence. That distinction is important as we think about the treatment needs of those individuals moving out into our communities. And of those, 31% meeting criteria for a co-occurring mental illness. On the mental health side of the equation, overall, 17% of individuals with serious mental illness, and of those, 3/4, both men and women, meeting our definition of co-occurring substance use disorders. This co-occurring issue is critical because the responses to individuals with co-occurring disorders are different than either having just a mental health or a substance use issues, and requires an integration of systems and an integration of practices. This is, again, a set of stats that we find in greater degree among women that are moving through our criminal justice settings. I throw the slides up here just for all of you that already know this, but these aren't of will or of choice. And if you, like me, has a family member with one of these illnesses, you know how painful that can be to the systems that they live within. These are brain disorders, and here is a slide of 2 individuals, one with depression, one without, and there are slight changes on this MRI, changes structurally in the hippocampus that suggest that that individual with mental illness over time ends up with brain-related changes that require some consistent attention. So too are substance use disorders, brain diseases. And here is a slide from NIDA, Nora Volkoff's laboratory, one brain on the left. This is a flow study into the brain of blood flow. And so here's a PET scan of a control and a normal, and what we see is a relative non-lighting up of the frontal cortex of this individual that's a cocaine abuser. And the important part of this slide is that that individual with cocaine abuse has been abstinent for 6 months, so that the changes that are induced through regular contact with drugs has a long-lasting impact on the brain and reflects the need for some of the longitudinal and continual care models that we know are so important in helping people move forward with their recovery. In terms of treatment principles for behavioral disorders, you gotta screen and you gotta assess. If you don't look for it, you won't find it. If you don't find it, you can't do anything about it. And that it's so important that at each juncture we use standardized and validated instruments to detect mental illness and or substance use disorders, whether it's coming at prison intake or jail intake or pre-sentence investigations or when the individual is coming out. We need to understand what their mental health and substance use disorder needs are. And with these screens that answer a question, might there be a problem, yes or no, those individuals with yes need to move forward into an assessment process that further delineates what the exact nature of the disorder might be so that treatments can be designed. And a one-size-fits-all response to substance abuse or mental health disorders isn't efficient, isn't effective, and we're going to talk about the need for matching treatment to the appropriate needs. It is that allows us through the course of this day to talk about targeting criminogenic needs and applying some of the cognitive behavioral interventions that are appropriate. We know that individuals in the justice system with mental health and criminal justice and substance use disorders have higher rates of the criminogenic risk factors that are associated with recidivism, and that oftentimes is an explanatory factor for why they recidivate at rates higher than those without substance use and mental disorders. We need to monitor drug use going forward, monitor medication adherence, but it isn't just pee in a cup and sanction. It's using this information to redesign, re-engage, rethink about the treatment interventions that might be necessary to enable that individual to make better choices going forward. We need to have integrated treatment for individuals with co-occurring disorders. We've had 2 decades of studies that show if you take an individual with co-occurring disorder and put them through traditional alcohol and drug services or traditional mental health services, their outcomes are no better than not going to those services at all. But when you bring together those services in the same place, with the same providers, with the same team, in an integrated fashion, you can get some of the outcomes that we all care and value, including the public safety outcomes that are the focus of our discussion today. It is also the case that when I say co-occurring or dual diagnosis or SAMI or MISA or whatever the term of art may be, it's just a reductionistic term for what that individual carries with them. So that there are chronic medical illnesses and social circumstances that must be understood if we're going to design a comprehensive response to that individual. On the medical end of things, rates of hepatitis B and C, HIV, AIDS infection, TB are staggering within criminal justice populations, but there's an opportunity there as well, a public health opportunity to identify and then move those individuals into treatment and provide it in some way that's consistent with continuity. So we spend a lot of resources inside the fence. I mean, of all citizens in this country, there's only one class that has constitutional protections to health care, and it's not our young and it's not our old, it's those individuals that are incarcerated. And so with that constitutional responsibility, we provide a set of screening, assessment, treatment, and discharge services for those individuals. And a lot of good work is done within those settings. But as a major theme of this presentation today, if we don't follow up that work into the community, then we have not used those resources efficiently at all. And we must decide that we're going to figure out mechanisms to pass this baton so that we can get the impact from the dollars that we're already spending. There are a number of answers to what works. What do we do with individuals with behavioral disorders in criminal justice settings? And that I put up here a sequential intercept model that says at every point of contact, from law enforcement on the street through discharge back to communities, there are things that we can do differently to impact recidivism rates for those individuals. And that we have heard already that there are specialized police-based responses, the most common of which you know of in crisis intervention teams, that have been shown to be effective in de-escalating issues on the scene and diverting individuals from booking centers and putting them back in touch with treatment. We have specialty courts, leaders. Justice Stratton as a nationally known leader in this area and has brought her talent to Ohio to disseminate mental health courts, drug courts, and specialty courts that do the job of identifying individuals, assessing what their needs are, setting conditions of release, linking them to treatment, and supervising them over time, the type of integrated strategies that we know are associated with good outcomes. We also know that from our literature, integrated treatment with supervision in both probation and parole caseloads can have an important impact on recidivism, and without it, those individuals with these behavioral health needs will not do well under those conditions of release and within community corrections. Here is, I think, a concept that we're trying to use, particularly in this era of scarce resources and the recession climate that we operate within. When we have a dime, we need to spend it on things that we know work, and we need to spend it on populations that need it most. And so in this very simplistic quadrant design, we have two axes, one that talks about criminogenic needs and risks of recidivism, and a second that talks about functional impairment related to substance use and mental illnesses, and that separates populations into quadrants, and that we really want to be thinking about those high-risk, high-need individuals if we're concerned about achieving public safety and public health outcomes. And so it is a way of targeting the scarce resources we have so we get the biggest bang for our buck in those dimensions. That's the national picture. Switching now for a moment to Ohio, and not telling you anything new. Big challenges in budget within the Department of Health, $134 million reduction in FY09 to 2011. Wish it was thousands, sorry, but it is million, and that actually, while it's 12%, Director Stevenson has reminded me that these dollars are actually coming mostly out of community resources, not the state hospital budgets, which are somewhat fixed. And as a result, the reductions at the community level to providing services are closer to 30 to 40% in reduction. Same is true on the substance abuse side of the house, where we've seen a $12 million reduction in general revenue funds, a 30% overall reduction in the service dollars available, at the same time that we have this expanding population within our criminal justice setting. So there's obviously, I like Senator Seitz's comment, the 5-pound bag won't hold the 10 pounds of need. We've got to make some decisions about what gets into the bag and how we get them there and how we use those resources as effectively as possible. When we look at some of the data that is available, they amplify the circumstances that we know all too well. People coming in on intake to our prisons have high mental health needs, high substance use needs, and have reported receiving services and using drugs and alcohol at high rates. It just confirms what we already know. The rates and prevalence of substance use disorders and mental illnesses in jail and prison settings are enormous. Need does not represent a diagnosis, and here I just wanted to throw briefly up from DRC Stats on those individuals coming into prison over time that were categorized as C1, some of the more severely mentally ill people within the system, and that's been fairly stable over time, is what I'm showing within this graphic. It is the case that when we look at those individuals, and earlier this morning we saw how important the probation, not new violator, but the probation violators, not new crime population, is to the growth within our prison settings. When we look at those new crimes versus probation violations, the percent of drug use among the probation violations and mental health indicators are higher than those in the new crime group that is coming through. So there's something about those 260,000 individuals on probation and their behavioral health needs that we need to attend to if we're going to slow the revolving door we've been discussing. In Ohio, as mentioned at points, we have terrific penetration of specialized police responses. There are over 74 counties that have received crisis intervention training. That represents over 3,700 officers. I was talking to Dr. Munitz earlier. Maybe it's 4,000 as we speak today, but it's an amazing penetration of this training into law enforcement. 350 law enforcement agencies with 25% or more of the force trained. It's 40 hours that one goes through. It's a significant commitment. But the officers know that when they get out on the street and encounter an individual that's got a mental health problem, a behavioral disorder, that they have tools to recognize and de-escalate, and then hopefully alternatives. Well, that's part of the story that I bring you. I want to thank again the Northern District U.S. Attorney Office that hosted over 25 police chiefs to talk to us about their experience on the street. And one of the common things that came through is that they all agreed that the CIT training that they got was helpful, de-escalated situations on the street, but you know what? the effectiveness of de-escalation and thinking about an alternative to booking is only good as the alternatives that exist. And if there aren't places to go, if you're a law enforcement officer and you can drop into Sallyport and give someone the report and 15 minutes later be back on the beat, or go spend 4 or 6 hours in an emergency room waiting for medical clearance, the choice isn't too difficult to make. And so off to booking we go. We need to have those alternatives in the community, but what we're hearing of late is that there have been restrictions on who the community providers can see, will see, are available to see. Restrictions on the violence that might be a part of the contact on the street, restrictions in terms of a co-occurring substance use disorder or current intoxication. These are all factors that limit the alternatives that law enforcement have within the state of Ohio. And a quote from one of the police chiefs, no matter how much CAT or de-escalation you do, you still rely on the medical institutions to wrap it up. And we can't seem to do that anymore, was a frustration that they expressed. When we look at the specialty courts, which have a growing research base to support their effectiveness in reducing recidivism, in connecting people with treatment, in improving community tenure, in achieving public health outcomes, you have a rich set of courts within this state. So over 75 drug courts, over 35 mental health courts at a variety of levels, all practicing therapeutic jurisprudence where a judge is allowed to think strategically with the support of community partners about what an individual's needs might be, what their public safety risk could be, if they're appropriate for an alternative to incarceration, make that linkage, access that treatment, and produce some of the good outcomes that we care about. However, even though this has been going on statewide, I'll just amplify one of the challenges that Justice Stratton outlined for you. Not a lot of data, not statewide systemized data available to drive court decisions. That's in the process of changing, as there's been a statewide case management database that's been established, and that there is consideration of the implementation of minimum standards to at least push some uniformity among the courts about who they take and what they do. When we think about integrated treatment and supervision at the probation and the parole level, what we understand is that 2/3 of the probation officer departments that we talk with don't have specialized officers that receive specialized training for how to interact with mental health or substance use probationers, and that is one of the best practices that isn't plentiful. And we also see that 2/3 said that there were insufficient mental health and substance abuse resources in their community to deal with their probationers. So that's another frustration that is expressed. Even when they know what needs to be done, accessing the care is difficult for them. Relating some of the information from the Common Pleas Judge survey that we sent out, and this is an important statement, I think, on the perceived availability of services within community. 63% of judges responding said they place offenders in halfway house and community-based correction facilities to connect them with needed mental health or substance abuse programming. Not based on a risk assessment, but a belief that at least there, this defendant will get some of the treatment needs met that they believe exist. And that of that group, 3/4 decided to do this because of a lack of available treatment in the community. So kind of a high-priced way to get treatment, it seems. At least at the bench, that is a decision that's being made to say, I know there's things that could benefit this person, and I'll get them any way I can, and if it has to be a CBCF or it has to be a halfway house, so be it. That's where they're going. We, with the data available to us, took a pass at estimating how much need there is for substance abuse and mental health among the probationers. And so we, again, limited our look to high risk and medium risk. And you see these numbers based on national data that talk about over 3,500 for substance use treatments, 800 for mental health treatment, 3,500 for both. The mental health treatment number is low because the co-occurring number is so high, and that the same sort of stratification you see within medium risk. These are big numbers, but they're not staggering numbers, and that there is some reason to believe that there is a way to bridge the gap between existing capacity and what the needs of these individuals are, if we are smart about how we target the resources that we're already spending within these systems of care. Also a part of the judge's survey, how effective would more substance abuse and mental health services be in increasing the number of probationers who would successfully complete their terms of supervision? 69% believed very effective or effective. So there's a willingness, and I think we've heard this from the bench, to consider the contributions of behavioral health disorders and attempt to manage, and they do it the best they can, but they're not able to access it in the lower cost community settings. This then sort of allows us to outline one of the challenges that you've heard throughout the day. The people come into court, they are convicted and sentenced to probation. There's a decision that gets made about, for those low-risk, nonviolent offenders, where they might go, whether it's out into the community or some of the community corrections alternatives. And this becomes a very expensive decision point. And that all too frequently it's being made based on what's available, sending people into the higher cost environments. Probation is then either terminated or completed, and then out they come from prison and community. So this is something that we think as a finding can suggest some potential remedies or policy directions that we might consider to be able to offer more alternatives to the judiciary. So what are the services that are needed? Where are they? Who's going to provide them? How are we going to pay for them? We have a big payment issue coming down the road here. We have healthcare legislation in this country which is going to allow everybody below 133% of the federal poverty level to be Medicaid eligible. It's a challenge. I mean, it's going to be a challenge to identify, enroll, and serve. But for those individuals we're talking about in our criminal justice population, a large majority of them are going to now have access to Medicaid that they never had before. And this is coming in 2014. We want to ready ourselves to make sure that they get access to quality care through the insurance that they're newly eligible for. When we think about the impact of service, and Director Stevenson alluded to this earlier, treatment provided through the linkage program associated with reduced recidivism, more treatment associated with greater change in recidivism. But we know that treatment is only half of the equation. So in a meta-analysis of studies conducted by the Washington State Institute on Policy and Practice, they looked at a range of studies that qualified as sophisticated in methodology and deduced from that that if you just provide treatment within a jail setting for drugs, you get no impact on recidivism. If you provide treatment in the community where that person lives, you can reduce recidivism by 8%. If you combine that treatment with effective supervision, now we're starting to get some of the bang for our buck. And recidivism rates are reported to go down by around 18%. So we want to be thinking about how we get on that 18% train. What are the mechanisms that we need to use to get folks there? How do we deliver the services? How do we develop the capacity for that to occur? In summing up and wrapping up where we are as at this point in the day, there are options that people have coming through our court-based system. There is the felony probation supervision option, which I just outlined for you, which with intensive services and supervision can get an 18% reduction in recidivism. There's the prison diversion option, attending to our halfway houses and CBCFs with the data from the recent Dr. Latessa survey suggesting about a 5% reduction in recidivism. And then there is providing them no service, the no service option, which is back to prison, 9 months, come out, 72% not supervised, back in the community. So those are options that are on the table. We want to make sure that we direct and promote the choice of those options that have the greatest impact on recidivism going forward. In terms of parole and the decisions that they face on reentry, not a major focus of our study, but I wanted to highlight the fact that there is good activity, that DRC with the substance abuse and mental health community have partnered around. There's a Medicaid initiative to ensure that folks that are eligible get identified and enrolled. That's going to be even bigger, as I alluded to, with the new healthcare legislation moving forward. There have been cooperative activities between these entities that have improved treatment stabilization. There's a new assessment process going on within DRC to categorize folks within their mental illness needs a little bit more clearly and accurately. There's the community linkage program that Director Stevenson referred to earlier that's going on that assists those individuals on exit from the prison to assure they get into community with the benefits and supports that they're entitled to, and that all of these are some of the positive things that are going on within your state. I show those and I show these as a suggestion that there are many bright lights here in Ohio. I didn't want this to be a too negative statement on what we find. There are lots of folks out there that know what to do and what folks need. There just aren't enough of these dots that are linked up at this point in time. So some of the other good services that we learned about in our tour of the state, the Ohio Substance Abuse and Mental Health Coordinating Center of Excellence, alluded to earlier by Director Stevenson, promoting integrated treatment for individuals throughout the state. We have some forensic assertive community treatment teams that have been funded in the north and the south, and this is an evidence-based practice that's labor-intensive, but it provides 24/7 supervision and treatment to individuals, assures that they get access to the appropriate treatment, and has been associated with reductions in recidivism. And then there is the whole issue of housing, which I haven't spent much time on here, but if you don't have a place to live, it's really tough to sort of make things work, and that Innovations with the Corporation of Supportive Housing has been sponsored around the state. These are all things and concepts that you've demonstrated you can do within the state, and now we need to make sure that we get the right people into the right programs to get the outcomes that we all care about. The bottom line summary, to kind of bring it back and to introduce our two panels for this afternoon, is that we have a revolving door here in the state of Ohio with more than 10,000 individuals, F4, F5 property and drug offenders who are sentenced to prison, spend about 9 months, get out without supervision, and that instead of the prison stay, maybe we ought to be thinking about short stays within treatment in the community with longer tails in terms of their probation so that we can monitor them more closely. We have no admission or unclear admission criteria for some of the diversion programs that are out there, and that we got to make sure that we're getting the right people into those well-funded, thoughtful facilities that operate within the state of Ohio and use CBCFs and halfway houses to address risk, not to address treatment need. That's not a smart use of resources. So we want to make sure they're driven by the risks of the individuals, not treatment needs, and that when they come into those facilities, appropriately diverted, and they get treatment, because CBCFs and halfway houses do provide a significant amount of mental health and substance abuse treatment. We got to make sure that when they come out, the baton is passed to the community team. And then lastly, this patchwork of probation supervision that exists. We need to figure out mechanisms so that we can get specialized probation initiatives for those probationers that would benefit from it. We need to make sure that when they're on probation, those POs have access to community-based treatment, because without effective treatment, effective probation doesn't get us where we want to go. And that this is a partnership between integrated treatment and supervision that's going to deliver the outcomes that we care about. So I think with that, I will say thank you once more, and we'll move, I think, into the panels that we have designed to further a discussion about these issues that have been presented throughout the day. So thank you very much.